Welcome to Lecture for Research Methods. I'll be talking about single experiment and quasi-experimental research. Research that's not quite experimental, but still wants to look at cause and effect relationships, but can't quite meet the standards we set for true experiments. Well, why would you do that? Why would you kind of use an approach that doesn't meet these kind of standards? Well, there's several reasons. One could be you're doing exploratory research. And you're just trying to find out if something can happen or if something does happen in the world. You're not necessarily looking right now to say, okay, I want to prove that this thing has an effect. I want to prove that this therapy works. You're just going to say, hey, I wonder if it can. And if you do that, you might not want to invest a whole lot of time and money in kind of this large-scale experiment with all these controls and all these different things. You might try one of these other approaches because you're just kind of starting out to see, hey, is this even possible? And then if you say, yeah, it is, then you follow up with more rigorous experimental research. Another reason is this is the type of research that might help bridge the researcher-clinician divide. And the researcher-clinician divide talks about this idea that in clinical research, the people doing the research often aren't full-time practitioners. They're often faculty members who may do a little bit of practice, but primarily are researchers. And most clinicians don't do much research. And so the research that's being done, the clinicians feel, oh, well, yeah, that's a neat study you did, but the way you looked at the question of if this treatment works or not doesn't look anything like I would be able to do it in my practice, right? You had 60 sessions or whatever it was, and you had this full team involved, and you had all these things, and that just happened in the real world. So you say, oh, this treatment works, great, but it won't work for me because I can't do what you've done in this lab. Your research looks nothing like my world, right? And then the researchers, by the same token, sometimes criticizing clinicians, saying, well, you're not using empirically supported treatments. You're just doing whatever feels right, and you need to use what we've shown works. And so they bicker back and forth. And so some of this research is a little less experimentally rigorous. Right, so which often means it's a little more real-world looking, and it can maybe be more likely to be conducted by clinicians or in partnerships between researchers and clinicians. And so because of that, the results of studies like this are often more accessible to clinicians, and they still have enough kind of oomph behind them experimentally for researchers to say, yeah, they have some validity. Another reason, if you have a question about the process, about how something happens, you may not want to do kind of, again, this kind of large-scale study to look at this group versus that group. You may want to look at, okay, I want to look at this particular problem with one or two people, maybe a small group of people, and over the course of a few weeks, a few months, whatever it is, how are these variables going to change? And what are the variables going to come into play? And these kind of alternative research approaches often allow for greater flexibility in terms of, a few weeks into your study, you go, oh, you know what, this might be a factor too. Let's start measuring this. Right? In an experiment, you can't just, in the middle of it, say, oh, let's start measuring this. You have to know what you're doing at the very beginning and follow the plan, follow the script. More flexibility in these alternatives. And last, sometimes when you have dual goals of research and intervention, where there's an intervention need somewhere in a community, perhaps, and so you need to design, some sort of a therapy, some sort of intervention to help people solve some problem, cope with something, whatever. And then another group of people are also interested in studying, well, does that really work, what you're saying you're going to do? Because if it works, we'll do it elsewhere. If it doesn't work, we'll find something else, right? So when both those goals collide in one place, sometimes you'll look for these alternatives to true experiments, again, where you have more flexibility and more accessibility to non-traditional researchers. Okay, one of the approaches talking about here in these kind of alternatives to true experiments would be single participant designs. And single participant can be a bit of a misnomer. Right? It's not necessarily a single participant, right? So, but it's usually a small number of participants, and it can be one participant. But it's not the same thing as a case study. A case study is where you're usually working with somebody clinically, typically, or you might just be in some other relationship with them where you're observing them regularly, and then you write about them kind of in a qualitative way. single participant designs are not qualitative designs. They are quantitative designs. You're recording data. You're taking measurements that are numbers. You're not just talking about how something happens. You're measuring things, and lots of measuring. There's a long history of single participant designs in behavioral research, going all the way back to Ebbinghaus. Remember back with the memory studies. Ebbinghaus developed the understanding of the forgetting curve. That you remember things for so long, and then memory starts to degrade. Very rather kind of steep curve to where you can't remember things anymore. And he did that with himself as the subject, right? He got a bunch of nonsense syllables, and he would memorize these lists of pages of syllables, and then test himself later. And he did it with enough rigor that even though there was only one subject, and it was himself, you think, wow, that's a lot of bias. But he discovered some really interesting principles of memory that are still cited today. So it's still good research, even though it's not maybe meeting the full standards of kind of a controlled clinical trial type thing. Same thing with B.F. Skinner often used single participant designs more often with animals, right? But again, where you can demonstrate a principle like operant conditioning, that it can work, and if it can work with one pigeon, unless you can make the argument that pigeon is just a genius, then it probably can be generalized to other pigeons, and that's what Skinner did. He'd show it once and then do it with other animals and more animals. But at the beginning, always doing it with just usually like one or two. It's easier when you're trying to figure out if something works to use a small number of participants. Okay, so what is a single participant design? Well, it features a couple things. One of the key features is repeated measurement. In a typical experiment, you may measure at one point in time and say, okay, is this group different than this group? Or if you're doing kind of a pre-post thing, you may do a little more, pre and post. Single participant, you're going to do a lot of more measurements than that, pre, post, and several points in between. Right? So one thing you're going to do is establish a baseline phase. Right? So imagine if you're using one person, and you're going to want to make the argument that something that you're doing to this person is changing their behavior, changing their anxiety. Right? Now their anxiety is going to be going up and down. So if I just measure them at one point, do something to them, and measure another point, it's pretty easy to make the argument, well, yeah, their anxiety is different, but it could be for a variety of reasons. You don't know that what you did really had an effect. You increase the validity of a single participant design by taking multiple measurements. So first, you measure their anxiety several times. So they come in on Monday, measure their anxiety. They come back on Wednesday, measure their anxiety. Come back on Friday, measure their anxiety. And if there's not a whole lot of variability among those measurements, we've established a baseline phase. And it doesn't have to be kind of a flat line. It doesn't have to be, okay, they were a 4, a 4, and a 4. They could be a 4, a 4.2, a 4.4, right? So either they're flat or they're trending, and they could be trending up, they could be trending down. But if they're a 4, and then a 7, and then a 4, well, we've got to keep measuring because we don't have a baseline yet. They're all over the place. We have to wait until there's something steady to be, okay, they're characteristically at this level, because we have to have some knowledge of what they're characteristically like on the dependent variable before we can do something to them and find out if we can change what they're characteristically like. Right? So you're going to make multiple measurements to establish a baseline phase. Usually it's at least 3 times, right? 3 points to make a trend. And then you may have some intervention. And then you don't just intervention and then measure one time. You do the same thing. You have multiple measurements to establish the treatment phase. So what are they like when I'm doing stuff to them or when I've done stuff to them? Again, to say, okay, if they were 4.2, 4.4, 4.6, we introduced an intervention and they're 4.4, 4.2, 4.0. Okay, that looks like evidence we've reversed the trend. Or it could be they were 4.2, 4.4, 4.6. We start the intervention and they're 4.6, 4.6, 4.6. Okay, that may still be an effective intervention. We may have leveled off their anxiety. We've stopped the upward trend, right? But if they're 4.2, 4.4, 4.6, intervention, 4.2, 4.6, 3.3. Well, we don't know what the heck's going on. They're all over the place. Again, we have to find some sort of stable trend. So one of the big things in repeated measurements is looking for stability. And stability is either, again, where it's level, where they're not changing, or there's some sort of trend. And it can be an upward trend or a downward trend. And typically we think of trends being linear. They don't have to be. They could be curvilinear too. As long as it's something predictable, then we can understand it. Another key feature is that participants serve as their own controls. Again, this is that kind of whole pre-post design. So in a single participant design, if you have more than one participant even, you're not usually comparing one person to another. You're comparing each person to his or her self, which in many ways is ideal because you're accounting for eliminating problems of a lot of the error variance that comes when you're comparing one group to the other group, because all of those groups could just be different. If you're comparing one person to him or herself, well, they're not different than themselves other than time and what you've done to them. So they serve as the perfect control. Right? Another important piece is experimental replication. And we talked before about in experimental studies where you find an effect and you say, okay, that's great. Now let's see if we can find it again. In single participant designs, you would do that in one study, right? And one of the most common ways to do that is use kind of a reversible design or an ABA design. This is where you're going to get some baseline, so that's A. So they're going along, they're doing whatever. And then you start doing something to them, your intervention, and you're measuring a treatment phase, so you're at B. So hopefully they're different. And then we'll take away the treatment. We go back to A, back to baseline, and see, okay, does their problematic behavior return? And so somebody's smoking a lot. We're doing something to help them stop smoking. So they smoke, smoke, smoke. We do something, they stop smoking, and we say, okay, stop doing the thing we taught you to do. And if they go back to smoking, then we've shown some control over the behavior. And it usually goes beyond that. We don't just take it away, so it's more like an ABA-B design. I usually leave them with the treatment. But if you can show control of the behavior within that single study, there's some fairly strong evidence for cause and effect. Again, even with just one person. Another key feature is visual analysis of the data, which I think many of you would be pleased to do in your studies. Not a lot of parametric statistics where you'd be using SPSS to run things. It's more often graphing, kind of like I show here in this picture where, okay, their behavior is down here, on the y-axis. It's pretty low for baseline at treatment. They were happier, assuming we're measuring happiness. And then we took away their puppy again, whatever it was, and they go back to being sad. And you just look at it and go, yeah, it looks like it had an effect. And there's not a statistical way to say, okay, are these dots higher than these other dots? Because it's just a different mindset when doing single participant designs than when you do your more traditional experimental designs. Okay. The simple reversal design we've kind of talked about is just one of the types. That's where you can have ABA or ABAB. So baseline, give some treatment, take away, so reversing the behavior, taking away the treatment, see if the behavior goes back down, and then we give it back to you, see if it goes back up. Shows control of behavior, which is nice. But there's some problems with that design, which you might imagine. One thing you have to wonder about is the effect of treatment reversible? Especially in a clinical setting, often you hope not, right? Somebody comes in and they're depressed, and you teach them some skills, new ways to think, right? So that's your B. It may be hard to take that away, right? So reversal design is often more effective with more kind of straightforward behavioral stuff, where you've got maybe a child or somebody with lower intellectual functioning. We're trying to stop them from headbanging or trying to get them to make their bed regularly, and you have some sort of reward system or punishment system or some combination. And often these type of designs are good for showing those types of things effectiveness, because as long as the behavior is being rewarded, it has high frequency. We take away the reward, the behavior drops in frequency. We put the reward back, behavior goes back up. So for those types of things, it can be effective. But for some treatments, it's not that simple because it's less external in terms of what motivates people to change their behavior. In therapy, we're often pushing for more intrinsic change. Right? Um, Additionally, in some settings, reversal design wouldn't be ethical, right? To withhold treatment might not be practical or ethical in some settings. So if other things you could do other than just a straightforward reversal design would be what they call a phase change design. This is where you have A, B, B1, A. So this is just a little spin on it, and this is where you can vary the treatment. So you have baseline, you give a treatment, and maybe they're not getting better. And again, this is where the flexibility of the single participant design is really beautiful and lends itself to clinicians doing this themselves. So somebody comes in, you get a baseline measure of how they're doing, you start a treatment, they're not getting better, you change the treatment. So that's what B1 is. It's some sort of modification of the treatment. So maybe they came in and you were doing some relaxation training and it didn't work. So now you've maybe either added to the relaxation training another component, some sort of guided imagery, or you substitute, taken away the relaxation training you're doing and added guided imagery to see, okay, now will the behavior change? And if so, okay, now they're feeling better. And then again, there's that reversal component potentially where you take it away. And if visually you see the changes in behavior, then you've got some evidence of cause and effect. Component analysis is just the same type of thing, so a little more complicated. And this is also referred to sometimes as dismantling. And you use it whenever you have some sort of multi-component treatment that usually is of known efficacy, that it works, but maybe it's expensive to do all the different things that are for that treatment, and you want to know, well, do I have to do all the stuff? Can I take something away? Right? So when you do that, you give them the full thing, which might be just two components, B and C, and then you take away one component. Okay, take away C. Now, how about if I just do B? Then you put that component back, and then you take the other one away, and then you put it back, and you see, okay, when does the behavior change? And so if taking away either component leads to a negative effect, then you need everything. If taking away one of the components doesn't have an effect, okay, well, I don't need both. I just need this one, and now I can have a maybe more cost-effective treatment. Okay. Another type would be multiple baseline designs. A couple ways of doing this. And you do this really when reversal designs are problematic. You can get around that by using multiple baseline designs. One way to do it would be to use multiple baselines across behaviors. So think about a simplest example. You measure, there's two problem behaviors, right? Both of which could be targets of treatment. You start measuring both of them. And then you begin treatment targeting one of them, but leave the other one alone. You keep measuring it, but you leave it alone. And then after a few weeks, few days, whatever it is, then you start treating the second behavior that you weren't treating before. And so if you see, okay, well, these two behaviors are going along, people aren't doing good, I start targeting one, it gets better, but the other one stays the same. Okay, now I've got evidence my treatment may be effective. And then, okay, now I start targeting the second one, and that behavior comes up too. Okay, yeah, now I've shown that without the treatment, both behaviors are down in the dumps, but once I start targeting treatment, they get better, right? And this gets, you do two behaviors because when you target one and leave the other one alone, and one gets better and the other doesn't, you're showing kind of that it really is more likely that it is your intervention rather than overall they were just getting better. Their life was easier, so they're getting better. Well, if they're getting better generally, how come this other behavior didn't change? Right? And the logical conclusion is well, that behavior didn't change because it wasn't targeted. And as soon as it was targeted, it changed. Right? So that way you don't have to take away treatment. You're just delaying treatment for one particular behavior. Another way to do it would be multiple baselines across participants. And this would be where you're measuring two people, a couple of people, and you just stagger when treatment begins. So two people come in, they both have anxiety. You're measuring them for 3 days. You start treatment with one and don't start treatment with the other for another week, and then start treatment with the second one. And again, you're looking for, will their anxiety only begin to change once I start treatment? Right? Because if two people come in and I start treatment with them both on the same day and they both get better, say, well, it could be some sort of history effect. It could be that the stock market had a big upturn around the same time, so everybody got happier and everybody got less anxious. Well, if I've got two people and I'm changing when I'm intervening with them, okay, it could have been the stock market because the one I didn't treat didn't get better until I began treating him or her. Again, showing that control over the behavior. The last type of multiple baseline design to talk about would be across situations. And this is where maybe you're looking at the same behavior, but at different times or in different situations. So somebody that has panic attacks that happen at the mall, they happen at work, they happen when they're at school, and maybe you target your intervention at only one situation. You're measuring all of them, but you only focus on treating one. And it gets better, the others don't, and then you start treating them, and then they get better. Again, you're showing control of the behavior, and that it's not just luck that these things happen to get better after you did a treatment. Because again, you're showing some differences here. Okay, in terms of limitations of a single participant design, I touched on it already a little bit. There may be some concerns about generalizability, obviously, but this, as I said before, depends on who you want to generalize to. Right? If you're just doing this type of research to help your client, the one person who's in your office, then it only needs to generalize to him or her, so it doesn't really matter. But if you're doing it for more kind of, well, I want to see if this works with other clients too, well, then it depends on how similar the client you worked with is to your other clients. And so there may be a need to replicate. So if you show no particular treatment is effective with a single participant design, you may want to do it with more people. And after you do it a couple times with single participant, you may then develop the larger experimental, clinical randomized controlled trial type study. Another potential limitation would be concerns about the effects of multiple measurements. Right? There's always a possibility of reactivity or sensitization. Just the idea that even without intervention, measuring behavior lots of times tends to change behavior. And to some degree, if you take enough measurements, you can account for this, and you can see, okay, well, did the behavior start getting better in kind of the baseline phase before I started intervention, just because I was measuring it. And you can sometimes kind of look at that, but again, it's a visual analysis. Okay. Quasi-experimental research is the other type of approach I wanted to kind of touch on here a little bit. And pretty straightforward. It's just not all the features of an experiment, but still interested in cause and effect. And typically looking at groups. Is this group different than that group? And typically, the feature of an experiment that you sacrifice to do a quasi-experimental research is random assignment. Typically, when you want to look at cause and effect, but you can't assign people to groups, but you're still going to do something to them, then that's a quasi-experimental study. Right? So you want to see, will this tutoring program improve scores, right? And so we institute it at one campus, but not another. Well, you couldn't assign people to go to those two different campuses, but you do have an independent variable. You are doing something to people, comparing one group to another. Because you didn't assign them to go to one campus or the other, it's not a true experiment. It's a quasi-experimental study. So a lot of people say, well, how is that different from causal comparative? Well, typically because you are doing stuff to people. Again, in causal comparative, it wouldn't be, I want to see if this tutoring program is effective. It would be, there's a tutoring program that's at one campus, another campus doesn't have it. It's already existing. People have already used the tutoring program. Are students at this campus doing better than this other one? Right? So I'm just comparing people after the effect has already happened. With quasi-experimental, you're still doing stuff to them. Right? And often you see quasi-experimental research too. If you have two existing groups and you do stuff to them, and you have kind of a pre-post component on top of that, right? Then you're really kind of adding to your ability to draw conclusions about cause and effect. So you have two existing groups, and if you just do two existing groups, do something to both, and then see if they're different. People say, well, how do you know they weren't already going to be different? because they're different groups. Yeah, good point. But if you do pre-post, then you can say, okay, did one group change more than the other? And if that happens, then you've got some interesting arguments to make about how those groups are different, and what it means to be in this group versus that other group. Last thing I want to touch on here is just clinical outcome research, because again, these alternative approaches to research other than experimental research are often used in clinical outcome research. So we'll talk just a little bit about some of the phrases that are thrown around in this arena. You hear about efficacy research and effectiveness research, and those are different things. They're not synonyms. Efficacy research looks at, can a treatment work? So if I do this, can people get better? Effectiveness research says, does this treatment work in the real world? So treatments differ on their focus. Efficacy research has a really strong focus on internal validity. If you want to say, can the treatment work, you want to be really confident that if you find a difference between groups or from pre to post, that it's because of the treatment and not because of some external factor. And when you want to have that confidence, you want to have lots of internal validity, typically you're going to be sacrificing some generalizability, right? And things aren't going to be very real world. You're going to have a manualized treatment. You're going to have therapists who are very trained to do the treatment exactly the way that it should be done. So I can really be comparing this treatment to no treatment versus comparing, something sort of like this treatment to no treatment, right? So big focus on internal validity for efficacy research, and focus on external validity for effectiveness research. So effectiveness is, okay, that's great, but when it goes out to a clinic, when it goes out to a community mental health clinic, when it goes out to private practice, when it goes out to a chaplain center, does it work? Do clients get better? And we'll talk about get better, what that means in a minute. Another issue in clinical outcome research is whether or not to use a control group or a comparison group, because often it's maybe unethical to use a true control where people get nothing. So if people in need of therapy, and one group's going to get no therapy, okay, that's not really ethical. So well, we'll get around it. We'll do a waitlist control. Right? So okay, please come be on our study, and you'll be randomly assigned to either receive treatment or be on a wait list for a month. Would you like to be in our study? And anybody that says yes is probably going to be different than somebody that says no. People that say no are probably going to be higher in severity of whatever that problem is, and they're not going to be willing to wait a month to get the treatment. Right? So when you use a waitlist control, the generalizability of results may be compromised because you may be looking at people who aren't that severe. So it might not really work for people who are more severe. Right? Which again, if you're doing efficacy research, maybe okay, you want to see, will the treatment work? And you can say, yeah, it does work. But then the question is, does it work with more severe patients? Don't know. Then you have to go do some effectiveness research, which probably isn't going to involve this kind of wait list. So it may be better to use a comparison group where you're comparing, okay, people that get this treatment versus this other treatment. And often it's the most ethical thing to do is the standard of care. So it's not something we think doesn't work. It's, well, what would they typically get if we weren't doing a research study? Right? So you want to say, is your intervention as good as or any better than what they would typically get? And that's an important question. And if it's as good as but not better, that may be important too, especially if your treatment is cheaper, more cost-effective, works more quickly. Right? Okay, I said before that one of the questions in the real world is, do people get better? So it's another just kind of important question to think about for clinical outcome research is, what's the outcome you should measure? What does it mean to get better? Somebody suffering from major depressive disorder, generalized anxiety disorder, maybe some substance use issues. If your treatment works, how will that person be different at the end of treatment than they were before? And how will they be different in a way that you can reliably measure? You could look at, do they meet criteria for a DSM diagnosis, which has its strong points and its weak points. There are certainly some parts of the DSM where, well, these symptoms are really kind of chronic, and treatment, you wouldn't expect treatment to make somebody not have the symptom more, but it may be less severe, less frequent, could be, or maybe it's amount of impairment or disability caused by symptoms. If that gets better, then they're better. So maybe you're looking at, okay, are they going to work? Are they going to school? Are they calling in sick? Are they getting sick? How's their physical health? Right? If you believe that mental health and physical health are tied together, maybe your treatment should have an effect on their immune system. Right? So the question of what is the right thing to measure is something that there's not any kind of easy answer to, and it really depends on what you believe about the goals of therapy and what the outcome should be. And then, in kind of in partnership with that, trying to think about, well, is that goal something I can measure reliably with any kind of degree of construct validity? Okay. Okay, that's all.